Good morning, everyone. I am Dr. Chanchal Bhandari, working as an assistant professor in Department of Cardiac Anesthesiology at UNMICRC Institute of Cardiology and Research Center, Ahmedabad. Today, we are discussing about the topic transesophageal echocardiographic assessment of pulmonary valve. So, it is anatomy of pulmonary valve. The pulmonary valve is a semilunar valve that separates the right ventricle from the pulmonary artery. It is situated anterior and superior to the aortic valve, almost at right angle to the aortic valve and parallel to the beam of ultrasound. So it has three cups, anterior, left and right. So these left and right are the posterior one, and these cups are thinner as compared to aortic valve. The annulus is smaller with an average diameter of 1.5 cm plus minus 0.3 cm and a normal size 3.5 to 4.5 cm square. So this is a pulmonary valve and aortic valve. They are almost perpendicular to each other, as you can see here. And being the most anterior valve, it is not well visualized on transesophageal echocardiography. So there are limited views from which we can assess the pulmonary valve. The first and foremost is midesophageal RV inflow-outflow view. So at about 60 to 90 degree, this view is created from midesophageal 5-chamber view, and it displays the right ventricular outflow tract and pulmonary valve with anterior right and left cuffs in the long axis. So this RV inflow-outflow view will show this is aortic valve, this is RVOT, and here you can visualize the pulmonary valve. So we can put the color flow Doppler may be used to detect the pulmonary regurgitation in this view. Next view is upper esophageal aortic arch short axis view. So from descending aortic short axis view, we have to withdraw the probe slightly until the aortic arch comes into view, and the multiplane angle is then rotated forward to 90 degree and turn right until the PA is seen, pulmonary artery. So this is pulmonary artery and pulmonary valve, they are in aligned parallel through the pulmonary valve and PA view, so beam can be aligned parallel. Next is transgastric RV outflow view. So from the transgastric 2-chamber view, the right ventricle is to be centered, and by turning the probe slightly rightward and advancing to 90 to 110 degrees, it will result in RV inflow view. So this is RV inflow view, this is right atrium, this is right ventricle, and here is a tricuspid valve. And from this view, by advancing the multiplane angle further until 110 to 145 degree and antiflexing the probe, we can see the pulmonary valve and RVOT. So that is transgastric RV outflow view. Another view is midesophageal ascending aortic short axis view. So from the midesophageal ascending short axis view, we have to slightly turn the probe to the right side. So in this view, we can see the main pulmonary artery and the right pulmonary artery, which is displayed on the right side of the screen, and pulmonary valve is not visualized in this view, while the left pulmonary artery is usually obscured by the bronchial structures. Now we'll talk about pulmonary stenosis. So the most common cause of the pulmonary stenosis is congenital. Other causes, it could be rheumatic or carcinoid disease, and right ventricular outflow tract obstruction from infundibular hypertrophy, as we routinely see in TOF cases, and aneurysmal membranous ventricular septum. So on 2D echocardiography, in pulmonary stenosis, the leaflet will be thickened and calcified with systolic doming. There will be restricted motion of the leaflets. There could be RV hypertrophy or enlargement, flattening of the ventricular septum, and post-stenotic dilatation of pulmonary artery. On Doppler, so on Doppler, in color flow Doppler, we will get the aliasing and turbulent flow across the valve. And when we see in the continuous view Doppler, we see a late peaking dagger gradient or dagger-shaped envelope in the right ventricular outflow tract. So, how to grade the pulmonary stenosis as mild, moderate and severe? In 2D, the leaflets will be normal in mild PS. It will be thickened with moderate restriction in moderate PS. And in severe PS, the leaflets will be thickened and calcified. The right ventricle will be normal in mild PS. In moderate, we see the mild hypertrophy, and in severe cases, there will be moderate hypertrophy. And the dagger shape gradient we calculate as a peak gradient. So this is important in the pulmonary stenosis. When your peak gradient is less than 36 mm of Hg, it is mild pulmonary stenosis. And when it is 36 to 64, it is moderate. And above 64 mm of Hg is considered as severe pulmonary stenosis. Now pulmonary regurgitation. Now functional PR, it is reported in 40 to 78% of the patients with normal pulmonary valve. The causes of pulmonary regurgitation could be the pulmonary hypertension with dilatation of pulmonary artery, post-repair tetralogy of Fallot, endocarditis or carcinoid disease. On 2D echocardiography, there would be annular dilatations, there could be vegetations, prolapse and lack of coaptation or dilatation of pulmonary artery. On color flow Doppler, it reveals a diastolic jet in the right ventricular outflow tract which is directed towards the right ventricle, is diagnostic of pulmonary regurgitation. And most PR jets are central because most of the time the cause is pulmonary hypertension, and it is considered significant only when the jet extends more than 2 centimeters into the right ventricular outflow tract. On continuous wave Doppler, the density of that signal provides a qualitative measure of regurgitation. Also, we can calculate the diastolic PA pressure can be calculated from the end diastolic PR jet velocity using the Bernoulli's equation. So, the diastolic PA pressure is 4 into diastolic PR jet velocity square plus right ventricular diastolic pressure or central venous pressure. So, how we grade the pulmonary regurgitation into mild, moderate and severe. So, the leaflets will be maybe abnormal in moderate, it is normal in mild, and severe it is abnormal. The RA-RV or pulmonary annulus ratio, it will be normal in mild. In moderate, it may be dilated, RA-RV, and severe it will be dilated. Jet length by continuous wave Doppler less than 10 mm is mild, 10 to 20 mm is moderate, and more than 20 mm is severe. And the ratio of jet width to RVOT diameter less than 34% is mild, 35 to 74% is moderate, and severe is above 75. And on continuous wave Doppler signal, the mild will be soft with slow acceleration. In moderate, it will be dense and variable. But dense and sleep deceleration signals, it is severe pulmonary regurgitation. So to conclude, the transesophageal echocardiography provides a practical and accurate method of assessing the pulmonary valve. In the absence of validated studies on quantitative measurements, an integrative approach, which includes the evaluation of chamber size, septal motion, color Doppler flow mapping, continuous wave Doppler recording of signal contour and intensity is recommended. Thank you.